Welcome to Weekly Neurology Deep Dive, where we take complex neurological research and distill it into clear, actionable insights for your clinical practice. Today, we're doing a deep dive into a really crucial paper, Biopsy-Confirmed Small Vessel Primary Central Nervous System Vasculitis, Clinical Features and Impact of Early Intensive Treatment on Remission, published by Reddy et al. In Neurology and Neuroimmunology, Neuroinflammation in 2025.
And just a quick but important note before we start, this deep dive is strictly for educational purposes. There are absolutely no commercial goals here. Think of it as a helpful summary, kind of a guide to your understanding, and we really do strongly encourage you to read the full paper for all the complete details.
Absolutely. And for those of you who need let's say, the key takeaway right now, before we even unpack anything, this was a single-center retrospective study. They looked at 26 patients, all with biopsy-proven small vessel primary central nervous system vasculitis. And they found that an early intensive treatment approach, specifically using cyclophosphamide, was associated with a significantly shorter time to remission. We're talking a median time to remission of just 5 months, compared to 19 months if an escalation treatment approach was used. So that's a dramatic difference.
It is. And while the study, interestingly, didn't show statistically significant differences in the overall remission rates or long-term functional outcomes between the two groups, that profound acceleration in time to remission, well, it fundamentally changes how we might think about initiating therapy in these often very challenging and debilitating cases for our patients.
That 14-month difference in getting to remission is just staggering when you think about it. Let's really unpack what that means for practice. So our focus today is specifically on small vessel primary central nervous system vasculitis. It's a rare autoimmune disorder, yes, but incredibly impactful, characterized by destructive inflammation of the brain or spinal cord's tiny blood vessels.
Right, and diagnosing it is complex. You absolutely need neuropathologic evidence of vasculitis from a central nervous system biopsy, or sometimes clear angiographic abnormalities, and crucially, alongside the rigorous exclusion of any other potential causes. It's especially important to differentiate it from large vessel primary central nervous system vasculitis, because the clinical pictures and, frankly, the optimal treatments can vary quite significantly. Patients with this small vessel predominant disease, they often present with things like cognitive impairment, seizures, abnormalities in their cerebrospinal fluid. And you also see areas of inflammation highlighted by contrast on magnetic resonance imaging.
Okay, let's talk about the specific patient population in this study. The researchers analyzed data from 26 patients, all diagnosed with biopsy-proven small vessel primary central nervous system vasculitis at just one institution. This was over nearly a decade and a half, from 2009 to 2023, and about half of these patients, 50% exactly, were female.
The median age when symptoms started was around 55.5 years. But as you often see, this covered a very wide range from patients in their early 20s right up to those in their early 80s. A really notable finding was that 7 of the 26 patients, so about 26.9%, were diagnosed specifically with amyloid beta-related angiitis, which is, a distinct subtype of small vessel primary central nervous system vasculitis. And what's particularly insightful here, I think, is that these amyloid beta-related angiitis patients were, on average, significantly older when diagnosed compared to those with non-amyloid pathology. We're talking about 73.9 years versus 50.3 years. And that difference was statistically significant, with a p-value less than 0.01. This age distinction is really a crucial differentiator to consider in your differential diagnosis, especially for older patients presenting with these kinds of symptoms.
Definitely. And when these patients first presented, what were the common symptoms? Well, they paint a clear picture of central nervous system involvement. Headache was reported by about 76.9% of patients, altered mental status in 61.5%, seizures in 38.5%, and focal weakness in 34.6%, a classic neurological picture in many ways.
And the neuroimaging, typically magnetic resonance imaging, frequently showed widespread lesions on specific sequences like T2-FLAR, often appearing in both hemispheres that was seen in 77% of patients. And abnormal gadolinium enhancement, indicating that active inflammation was seen in a striking 88.5%. But a key point here is that intracranial vascular irregularities, the kind that would suggest involvement of larger or medium vessels, they were actually quite rare, observed in only 11.5% of this specific group, which really reinforces the small vessel nature of the disease in this particular cohort.
Interesting. And among the patients without amyloid beta-related angiitis, that was 19 patients, a small proportion of 15.8%, showed spinal cord involvement. And 21.1% exhibited isolated intrahemispheric disease, which, as you know, can sometimes be a tricky presentation to diagnose.
Cerebrospinal fluid testing was performed on 23 of the patients in the study. And while a mild increase in cerebrospinal fluid white blood cells, pleocytosis, was often present in about 65.2% of patients. It's really important to note that a significant minority, 17.4%, had a completely normal cerebrospinal fluid analysis, which just highlights the diagnostic challenges and the heterogeneity we sometimes face with this condition. Oligoclonal bands were found in about 30.4% of patients tested.
And the diagnostic journey itself, well, it can be quite complex and unfortunately protracted for both patients and clinicians. The median time just from symptom onset to getting that definitive biopsy-supported diagnosis was around 4.6 months. And in fact, nearly a quarter of the patients in this study, 23.1%, actually underwent a repeat brain biopsy because their initial findings weren't definitive. So given this challenging diagnostic landscape and the delays that are often encountered, what did the researchers actually discover about the most effective treatment paths? The study specifically looked at the impact of initiating immunosuppressive therapy early and intensively.
Yes, and this is truly an important question. The optimal treatment for primary central nervous system vasculitis has been, well, a subject of some uncertainty. Approaches have varied, from just glucocorticoid monotherapy all the way to very aggressive early treatment. So the study thoughtfully stratified patients into two distinct treatment groups to compare these strategies. First, the early intensive treatment group. This included 12 patients. They received cyclophosphamide, either intravenously or orally, within 3 months of starting any immunosuppressive treatment. And they continued that cyclophosphamide for at least 3 months. The regimens varied a bit, could include things like dosing based on the cyclophosphamide trial, or monthly IVIG infusions, or daily oral dosing. Then second, you had the escalation treatment group. This consists of 14 patients. They initially received glucocorticoids, either alone or sometimes with other immunosuppressants like azathioprine, mycophenolate mofetil, or methotrexate. This commonly involved, pulse dose intravenous methylprednisolone, followed by oral steroid tapers before potentially escalating to more intensive agents like cyclophosphamide later on if needed.
Got it. And how did they define remission and relapse? Remission in this study was defined by clinical stability or actual improvement, meaning no new or worsening neurologic symptoms that could be directly attributed to the primary central nervous system vasculitis, and, importantly, no evidence of new or worsening lesions on magnetic resonance imaging. Though it's worth noting that complete resolution of enhancement on the imaging wasn't a strict requirement for defining remission. Relapse, on the other hand, was defined pretty clearly. Imaging worsening consistent with vasculitis, with clinical correlation after a patient had already achieved remission.
Okay, now for the really critical findings concerning these treatment outcomes. All 12 patients in the early intensive treatment group, that's 100% achieved remission. Yeah. Every single one. In comparison, 11 out of the 14 patients, or 78.6%, in the escalation treatment group achieved remission. Now, while this certainly shows a trend favoring the early intensive treatment, the difference in the rate of remission between the groups wasn't actually statistically significant. The p-value was 0.22.
Right, but here's where the truly impactful clinical insight emerges, as you said earlier. The time to remission was dramatically and statistically significantly shorter in the early intensive treatment group. The median time to remission was just 5 months in that early intensive group compared to 19 months in the escalation treatment group. That's a 14-month difference, which, for a patient dealing with a debilitating neurological condition like this, is simply profound. It's a huge amount of time.
It really is. And the statistics strongly back this up. The hazard ratio was 0.24 with a p-value less than 0.01, indicating that patients in the early intensive group reach remission nearly 4 times faster than those in the escalation group.
Yeah.
That's a powerful finding.
Absolutely. Now, what about functional outcomes? They use the modified Rankin scale, which gauges disability. At the start of treatment, about a third, 33.3% of the early intensive group and just over half, 57.1%, of the escalation group had what was considered good functional status and MRS score below 3.
Right. And then after 2 years, they looked again. Functional improvement, meaning a decrease in the modified Rankin scale score, was seen in 50% of the early intensive treatment group versus 35.7% of the escalation treatment group. This resulted in about 2/3, 66.6% of the early intensive treatment patients and roughly 42.9% of the escalation treatment patients achieving that good functional status at 2 years. So while the early intensive treatment group definitely showed a positive trend towards better functional outcomes, these differences weren't statistically significant in this particular study. The p-values were 0.69 and 0.27 respectively.
Okay. And what about the side effect profile, specifically looking at steroid exposure? That's always a major concern. The mean cumulative glucocorticoid exposure by the time remission was achieved was 13.4 grams in the early intensive treatment group and 17.5 grams in the escalation treatment group. Interestingly, this difference was also not statistically significant, with a p-value of 0.36.
Exactly. So that much faster time to remission in the early intensive group didn't seem to come at the cost of a significantly higher overall steroid burden, at least up to the point of remission in this cohort.
That's encouraging. And looking longer term.
Well, among the patients who did achieve remission, regardless of group, the overall relapse rate was 19%, which I think suggests that maintenance therapy after achieving induction is likely warranted. And this finding aligns pretty well with observations from other primary central nervous system vasculitis cohorts. Relapse is definitely a risk.
The study also gave some practical insight into why some patients ended up in the escalation group and didn't get cyclophosphamide right away. Reasons included things like diagnostic uncertainty, which led to empirical immunosuppression before they had the definitive neuropathologic diagnosis. That happened in 7 patients.
Yes, and also poor functional status making. Physicians, perhaps hesitant in 2 patients, shared decision-making or specific patient preference in another 2 patients, and even pregnancy in 1 case. It really highlights the real-world complexities and the factors beyond just the disease itself that influence our treatment decisions day to day.
So let's bring it all back to daily practice. What does this study mean for us as neurologists when we're managing patients with suspected or confirmed small vessel primary central nervous system vasculitis? This is the question clinicians grapple with constantly, isn't it?
It is. And what's truly compelling here, I believe, is that this study really underscores the significant clinical heterogeneity we see in small vessel primary central nervous system vasculitis. It's not one single entity. But despite that variability, the very strong association of using early intensive treatment with cyclophosphamide with that dramatically shorter time to remission that is a pivotal finding for us neurologists. It strongly suggests that maybe these escalation approaches, like starting with just glucocorticoid monotherapy and waiting, probably shouldn't be considered the optimal first-line therapy anymore for biopsy-proven small vessel primary central nervous system vasculitis.
That's a big shift, and this finding really underlines, critically, the need for timely and accurate diagnosis, particularly getting that central nervous system biopsy when you suspect small vessel primary central nervous system vasculitis. Knowing that starting intensive treatment early can so profoundly affect the disease course, well, it means getting that definitive diagnosis as quickly as possible is more important than ever before.
Absolutely, and this also raises important questions about future therapeutic directions, doesn't it? While cyclophosphamide clearly remains a cornerstone for induction based on this, the cumulative glucocorticoid exposure, even if it wasn't statistically higher in the intensive group here, is still substantial overall. So future research really should explore strategies to mitigate glucocorticoid toxicity, perhaps looking at novel agents, things like complement inhibitors, which have shown some promise in other forms of vasculitis. And additionally, therapies like anti-IL-6 receptor therapy, anti-CD20 therapy treatments already used in other vasculitides, they certainly warrant investigation as potential induction agents in small vessel primary central nervous system vasculitis too. We need more options.
And another practical point that came out of the study for those patients who had abnormal cerebrospinal fluid at baseline, the resolution of those abnormalities often correlated quite well with achieving clinical remission, which suggests that, repeat cerebrospinal fluid analysis could actually be a very helpful tool in assessing treatment response. It gives you a concrete, objective measure to track during follow-up.
That's a great point. And we must, of course, always acknowledge the inherent limitations. This was a retrospective study. So there's potential for confounding factors influencing treatment choice and response, maybe variability in follow-up assessments. These things are hard to control completely retrospectively. However, the rigor of focusing exclusively on biopsy-proven cases does significantly minimize confounding from non-vasculitic mimics, which is a strength. And the diversity of the clinical spectrum they captured, including phenotypes like relapsing unihemispheric disease or spinal cord involvement, also suggests that perhaps more tailored approaches might eventually be needed for these potentially more aggressive presentations.
So ultimately, this deep dive really emphasizes that while primary central nervous system vasculitis covers a broad and challenging spectrum of diseases, this specific research focusing on the small vessel disease provides some pretty compelling evidence for us to consider an early, aggressive treatment strategy. Further validation in larger cohorts and ideally randomized controlled trials is certainly warranted. But the data we have here offers a strong rationale for considering immediate clinical action in the right setting.
Exactly. So to reiterate that core practical summary for your practice, for patients where you have biopsy-proven small vessel primary central nervous system vasculitis, early intensive treatment with cyclophosphamide was associated with a significantly shorter time to remission. Remember, a median of 5 months compared to 19 months for escalation therapy. And while the overall remission rates and long-term functional status didn't show statistically significant differences in this particular study, that acceleration of remission is a powerful and I think very practical consideration for immediate clinical action. Getting patients better faster matters immensely.
This has been, I think, a crucial weekly neurology deep dive into a complex and often very challenging condition. Remember, the nuances of each patient's presentation and their specific biopsy findings are absolutely critical. The information we've shared here is designed to help you stay well-informed and apply the latest research in your practice with, hopefully, greater clarity and confidence.
And we truly encourage you to delve deeper yourselves by reading the full paper by Reddy and colleagues from 2025. There's always more to learn, and considering multiple perspectives, reading the source directly only enriches our understanding as clinicians.
Thank you so much for joining us for this weekly neurology deep dive. We hope this conversation helps you navigate the complexities of small vessel primary central nervous system vasculitis. This deep dive was produced by Amer Gavanini. Until next time, keep digging for those insights.